Now, when we talk about respiration, we're talking about two processes. We touched on them a little bit earlier in the previous segment, and one of them is this idea of external respiration. And that's where we're bringing the gases in from outside, the oxygen, bringing it in, we're exchanging it across the alveolar surfaces with carbon dioxide that's coming from the inside, from the interstitial fluids. And basically, we're promoting this exchange of oxygen and carbon dioxide from the internal environment to the external environment. Now, internal respiration is what causes us to have the need to do this, because the internal respiration comes about because of cellular respiration. Because what the cells are doing, the mitochondria in the cells are taking oxygen and creating ATP. And as a byproduct, would create water and carbon dioxide. And carbon dioxide is going to have to be off-gassed, so it's going to have to be transported through the interstitial fluids into blood and so forth, where blood will travel to the lungs, and then we can do our external respiration, which is exchanging the carbon dioxide from the interstitial fluids to the outside with the oxygen that we just brought in from the outside, so that we can then bring it inside. All right. So the process of external respiration begins with pulmonary ventilation. That's simply breathing. That's breathing the air into the lungs. Then we have the gas diffusion across the membranes into the capillaries and then into the blood supply. And then we're going to have the transport of oxygen between the alveolar capillaries, then eventually back to the lungs, then to the systemic circuit, and to the capillary beds in other tissues. And of course, when oxygen's coming one way, of course, carbon dioxide is going the other. All right, so here is our pulmonary ventilation. That is the act of bringing air into and out of the lungs. We have our gas diffusion from the alveolar surfaces into the bloodstream, and we're going to have, well, we'll have oxygen coming this way, so oxygen will be absorbed across the alveolar surfaces, or I should say, will diffuse across the alveolar surfaces and then be picked up by the red blood cells, and then it will be transported to the interstitial fluids around cells, where it will then diffuse into cells that can then use that oxygen for its cellular respiration. And then, of course, they're going to create carbon dioxide, which will then be picked up by the circulatory system, brought back eventually to the lungs, where we can off-gas this stuff. So the pulmonary ventilation is bringing air into and out of the lungs. The external respiration is this exchange of gases with the interstitial fluids, gases from the outside with the interstitial fluids and vice versa. So we've got gases being off-gassed by the interstitial fluids that are brought through the circulatory system. And of course, then we have the gas diffusion, internal respiration from those interstitial fluids into the cells that then use them. All right, so pulmonary ventilation, as we've said, is the movement of air in and out of the respiratory tract. And that is going to bring the air into the lungs. And of course, in the lungs, we can now have alveolar ventilation, and that's basically going to be allowing air into the alveoli. And then here we can exchange the oxygen for carbon dioxide and so forth. Now, the movement of air in and out of the lungs is entirely due to pressures and differences of pressures inside the lungs versus outside the lungs. And so we have the atmospheric pressure, which is the weight of the air, and that's going to determine the external pressure outside of our lungs. Now, we have a simple bunch of rules from physics that you probably remember, one of which was Boyle's law. And that basically says that if you have a container and you have a certain amount of volume in this container and you have so many particles in this container, they're all going to be bouncing around randomly, and that's going to create a certain amount of pressure. If you increase the volume by twice, well, then you reduce the pressure by half, because now those particles have twice as much space to move around in. They're not hitting the surfaces or each other as often. Likewise, if you reduce the volume to 1/2 of what it was when you started originally, you increase the pressure by twice, because now these particles that are inside, in our case it's going to be the air molecules, will be hitting each other twice as often and hitting the surface of the walls now. So basically, it's just like blowing up a balloon. So in order to blow up a balloon, it starts off with a very small volume. You actually have to exhale quite forcefully to get the air in that balloon. And then when you tie it off, you have a much higher pressure inside the balloon than you do outside the balloon. And if you were to create either untie the balloon, the air would let off very, very rapidly, or worse yet, if you hit it with a needle, pop, it pops immediately because there's more pressure inside than out. And that pressure wants to move, or those air molecules want to move from an area of high pressure to an area of low pressure. So that's exactly how it's going to work in the lungs. Here we have some regular atmospheric pressure here, and if we start off in the lungs with the lungs being equal pressure as the outside air, and then we expand our lungs by expanding our thoracic cavity, then we decrease the pressure in the lungs because now the air molecules have more room to move. And so, of course, air from the outside is going to want to come in. It's just kind of like diffusion in liquids, except now we're dealing with movement of air particles in an air medium. So if you decrease the volume, then the molecules in the container are going to hit the walls and each other much more frequently, and they're going to try to get out. And so if we decrease the volume of the lungs, so for example, when we exhale, then the thoracic cavity gets smaller. And those particles, those air molecules, are going to have less room to move, and so they're going to try to leave. And of course, they can leave through the conducting passageways, and then they can then be exhaled back out to the atmosphere. So typically, when we're at rest, before we take a breath, the pressure inside and outside our lungs is going to be equal. So this is what's going to cause inspiration and expiration. So our respiratory cycle is going to consist of one inspiration, and that's basically air moving from higher pressure to lower pressure as we increase the size of the thoracic cavity, and then an expiration when the air is moving from higher pressure to lower pressure as we decrease the volume of the lungs. And of course, we're having more air that we just inhaled. That's going to want to go out to the external air again. So pulmonary ventilation basically is going to cause volume changes that create these changes in pressure. So as the volume of the thoracic cavity changes, the pressure inside is going to change. And that's going to pull air in or force it out. So how does it work? Well, we've got our diaphragm here. And the diaphragm, when it's relaxed, just kind of forms this dome up into the thoracic cavity. But as you contract it, the diaphragm pulls away. It becomes shorter. And so it pulls away, and it's going to increase the thoracic and some of the intra-abdominal volume here. And at the same time, we're going to have the external intercostals, which are some muscles between the ribs. They're going to raise the sternum and the ribs. And that's going to create this much larger volume within the thoracic cavity. So now more air is going to run in there. So basically what we're going to see is when we start, we're going to have pressure inside being the same as the pressure outside. So here's our diaphragm. It's kind of in a neutral position. Here are our lungs. And we're going to see that we're going to increase the volume of the lungs. Now, interestingly, the lungs have quite a bit of elasticity. And once they exhale, they'll want to recoil. And they would recoil to a much smaller size than they would ordinarily if they weren't inside the pleural or surrounded by the pleural cavity. So the pleural membrane is going to be very important for preventing the lungs, because they're very elastic, just from collapsing to about 5% of their volume on an exhalation. Because we've got, remember those elastic fibers that are surrounding each alveolus. So these are quite powerful, and the lungs are very elastic, and they would want to recoil to their smallest possible volume. But we have some surface tension within inside our parietal and visceral pleural membranes because we have our serous fluid inside. And this creates a surface tension, and this is going to create kind of a suction. And so this is actually holding the lungs to the body wall, this surface tension within the pleural membrane. So basically we have the serous fluid, which is going to hold it, the visceral and parietal layers of the pleural membrane together. And remember, the lungs are going to be attached to that visceral pleura. Now, if this weren't there, or somehow this were damaged, the lungs would collapse. And that's exactly what happens in a pneumothorax. All right, so in typical ventilation, and first we're going to bring air into the lungs, we're going to increase the volume by pulling the diaphragm down and raising the ribs and the sternum. So that's going to make the thoracic cavity bigger. So now we've increased our volume. So now air is going to want to come in. And so this will be our inhalation. Now when we have inhaled, our pressure inside will have basically equalized with the pressure outside to accommodate the larger volume. But now we exhale and basically we decrease the volume, and now we're going to force air out of the lungs until the relative concentrations of air molecules are the same on either side. So what's going to happen is we're going to force air out of the lungs to accommodate that smaller volume so that the internal and external concentrations of air inside and outside the body are going to be the same. And then we'll just keep going in this process so that we cycle through this process. So this is a respiratory cycle. So when we breathe about 500 milliliters at rest per inspiration. And so for every inspiration, we have an equal amount of exhalation. So we can basically look at the pressure inside or outside the lungs. And when the lungs are at neutral, that is when they're not inhaling or exhaling, then the pressures are going to be the same inside and outside. So typically, it's going to be about 1 atmosphere of pressure. Of course, this is going to vary whether you're at high altitude or low altitude. But at sea level, it's typically about 760 millimeters of mercury, and that varies from day to day. And that's a whole different topic of density, altitude, and other things. But one thing that's important to be aware of is that when you go deep underwater, then you have a lot of pressure on the thoracic cavity. And the lungs, if you hold your breath, they're actually going to reduce in volume quite a bit. So for every atmosphere, which is 10 meters, 33 feet, you go down, your lung size will actually decrease by half. And so this becomes an important consideration when doing any kind of diving. Because if you're just holding your breath, that's fine. When you come back up, your lungs will expand out to their normal volume. But if you're breathing compressed gas through air tanks, then your lungs are going to fill up to their full size. So when you're underwater, let's say you're at 1 atmosphere, then your lungs are going to be filled with compressed gas. If you then held your breath and went to the surface, your lungs would try to expand to twice their size and they would burst. So you could have a major problem if you did that. So it's important to understand the pressure relationships between the lungs and the external environment. And for our discussion, we're going to be sticking to just basically what we experience in the air every day. And we're going to consider it 1 atmosphere, about sea level, so 760 millimeters of mercury. So we're going to have what's called the intrapulmonary pressure, which is also called the intra-alveolar pressure, and it's completely relative to the atmospheric pressure. So in relaxed breathing, the difference between the atmospheric pressure and the intrapulmonary pressure is small. And we're talking about the pressure at the alveolus here. So the intrapulmonary pressure is going to range from about -1 millimeter of mercury on inhalation. As the chest thoracic cavity gets bigger, then we're going to have about 759 millimeters of mercury on the inside. And of course, that extra decrease in pressure is going to bring air in. And then when we exhale, then it's going to be about +1 millimeter of mercury on exhalation because our thoracic cavity is getting smaller. And now we're going to have a slightly higher pressure on the inside than outside. That's going to force air out. Now, this is during normal, regular breathing. If we were to get involved in some kind of really strenuous activity, this could change, for example, to -30 millimeters of mercury on an inhalation if we're doing highly strenuous activity. All right, so we have, as we've said, about -30 millimeters of mercury. And if you're really straining, let's say you're going for your 1 rep max on your squat or your deadlift, and you're closing your glottis, which you don't want to do for very long, and you're increasing that intra-abdominal pressure, and intrathoracic pressure, it could be up to 100 millimeters of mercury. So if you really, really strain hard, too hard, and you forget to breathe, this can be problematic. And people have died from it, actually. So you don't want to strain too much. All right, so the interpleural pressure is a little bit different. And this is going to be that space between the parietal and visceral pleura. So it's going to average about -4 millimeters of mercury. And here again, this is to prevent that elastic recoil of the lungs. So this keeps it from basically, it prevents the lungs from collapsing on themselves. So it's going to be about an average of -4 millimeters of mercury, and then it can be as low as -18 millimeters of mercury. And it's always going to be below the atmospheric pressure throughout the respiratory cycle. All right, so the respiratory cycle itself is cyclic changes with the intrapleural pressure, which are going to be acting as that respiratory pump. Remember earlier when we talked about the cardiovascular system, how venous return, part of what helps it get back to the heart is not just muscular action, but also the actions of the respiratory pump, which is going to help bring the venous blood back to the heart against gravity. Now, the tidal volume is the amount of air moved in and out of the lungs in a single respiratory cycle. And when we're at rest, it's about 500 milliliters of air. And so this just summarizes our intrapulmonary pressure here and our intrapleural pressure. So our intrapulmonary pressure basically is going to range between -1 and +1. And this is during a single respiratory cycle. The intrapleural pressure will range, it's always a little bit lower than the outside pressure, so ranging somewhere between -2 and -6 typically during a single respiratory cycle. And then we have our tidal volume, which is about how much air we inhale. And of course, we're going to exhale the same amount of air that we inhale. And so our tidal volume is just going to be whatever we inhaled. So it's going to be 500 milliliters, because in this case, if we're just resting. If we're doing some strenuous physical activity, that could increase quite a bit. But nevertheless, however much we increase, that's what we're going to exhale during a single respiratory cycle. All right, so if you have air get into the pleural cavity, this is what we're talking about when we talk about pneumothorax. This is going to basically destroy that surface tension on the inside of between the two mesothelia of the serous membrane, the pleural membrane, and that's going to allow air in there. And so now you're going to lose that negative pressure. And so now that's going to allow the lungs just to recoil in on themselves. And this is why people get collapsed lungs. Or sometimes they'll get a sucking chest wound where they can breathe, but the air will not fill the lungs. Then we also have, atelectasis is the technical term for a collapsed lung. All right, so the respiratory muscles, we're going to see that at rest, we're going to have basically inhalation is an active process and exhalation is a passive one. So the most important muscles in respiration are the diaphragm and also the external intercostal muscles of the ribs, because the diaphragm is going to pull down when it's contracted, and that's going to increase the thoracic volume from the bottom, and the external intercostal muscles will lift the ribs and the sternum. So we're going to increase the thoracic volume that way. And we can have, if we're going to be doing some severely strenuous activities, we can start to recruit other muscles as well, like the sternocleidomastoid, like the serratus anterior and so forth. So this is going to help us inhale more when we need to. Typically, when we're at rest, then the exhalation is going to be a passive process entirely. All you have to do is relax the diaphragm and the external intercostal muscles. We'll see that we have some accessory respiratory muscles as well. So, for example, if we want to increase our ability to pull air into the lungs, we might start to recruit things like the sternocleidomastoid, scalene muscles, which are muscles of the neck. We might recruit the pectoralis minor to help lift the ribs. We might even recruit the serratus anterior. And these would help us get even larger inhalations. And these are accessory respiratory muscles. by the same token, if we're really breathing hard and we have to force more air out of the lungs, we might recruit some accessory respiratory muscles, such as the internal intercostal muscles, the thoracic transversus, and the abdominal muscles. So when we think of breathing, we've got to remember that inhalation is always active. It's always going to involve at least the diaphragm and the external intercostals. Exhalation is passive until we start getting really into strenuous activities, and then we might need some extra help in decreasing the volume of the thoracic cavity to keep up with the amount of increase that we had on our inhalation. All right, so the diaphragm, when we are quiet breathing, which is called eupnea, when we're doing quiet breathing and we're having our active inhalation and our passive exhalation, the diaphragm accounts for most of the air that comes into the lungs, so about 75%. And the external intercostal muscles can account for about 25% of movement. And typically, if we are breathing normally, then we will have a lot of it's diaphragmatic breathing, which is the movement of the diaphragm. But if for whatever reason we have pressure or something accumulating in the abdominal cavity that's forcing the diaphragm up into the thoracic cavity, then we might have to rely more and more on the intercostal muscles. And this is an example of what you would see during pregnancy. So as the mother becomes closer to the due date, then the baby is getting bigger and putting pressure on that diaphragm, which is going to push up into the thoracic cavity. So they're going to be relying much more on the external intercostal muscles. Now, as we've said, we've got some accessory muscles that can help us breathe in, that is, elevate the ribs, as we've said, the sternocleidomastoid, the scalene muscles, both of which are in the neck. The serratus anterior, as you remember, are coming in around here, and the pectoralis minor, which is basically going to have its origin on the ribs and its insertion on the coracoid process. So these things can help us elevate the ribs. And these are accessory. These are not usually engaged in quiet breathing. So here are some examples. Here we have our primary respiratory muscles, the diaphragm here, and the external intercostal muscles. Here's our sternocleidomastoid, which, as you recall, has its origin on the sternum and the clavicle, and its insertion on the mastoid process, hence the name. Scaling muscles are also some neck muscles. Pectoralis minor, it's cut here, but we've got our origin on the ribs and our insertion on the coracoid process here. And then we've got our serratus anterior here, which is also going to help us expand the rib cage. Now, if we want to contract the rib cage, we've got some internal intercostal muscles, which can help pull the ribs together. The transversus thoracus muscle over here, and the external abdominal oblique, as well as the rectus abdominis and the internal oblique as well. All right, so just a quick overview on the movements that are actually happening during pulmonary ventilation. The diaphragm is going to contract and move down and outwards. So typically when it's relaxed, it's just this dome poking up into the thoracic cavity. As the diaphragm contracts and moves outward, the external intercostals are going to raise the ribs in the sternum, and then we're going to have this increased diaphragmatic volume. All right, so here's some examples of the muscles again used in inhalation and how they're working. Diaphragms pulling down and out this way, and the external intercostals are going to be lifting the ribs in the sternum. We can also recruit our sternocleidomastoid, our scalenes, our pectoralis minor, and our serratus anterior as well. So when we exhale, remember that typically exhalation is a passive process. But when we start our active breathing, which is called hyperpnea, when we start active breathing, that is recruiting these accessory muscles, and we actually are going to use muscular activity for the exhalation, then we're going to bring in the internal intercostal muscles, the transversus thoracus muscles, and the abdominal muscles. This will depress the ribs and compress the abdomen, forcing the diaphragm upward and squeezing the thoracic space even into a more constrained space. All right, here are those muscles. Here we have our internal intercostal muscles here. Our rectus abdominis is going to tighten. That's going to force the contents of the abdominal cavity closer towards the back body wall, that's going to have the effect of pushing the diaphragm up into the thoracic cavity. All right, so as we've said, we've already talked about this already. We've got quiet breathing. That's what happens when you're just sitting around watching television or studying or what have you. This is where you have basically the diaphragm and the external intercostals are causing the inhalation, and then you have completely passive exhalation just by relaxing those muscles. When we have forced breathing, that's when we're recruiting these other accessory muscles. So quiet breathing is often called eupnea, and forced breathing is called hyperpnea. So basically we're going to have the quiet breathing, we've already talked about this, diaphragmatic contractions dominate the breathing pattern, and costal breathing is shallow breathing. That's going to be basically the hinging of the rib cage, allowing it to expand upward. And typically the diaphragmatic breathing is going to contribute to most of our inhalation, unless of course you have something in the abdominal cavity that's forcing the diaphragm up into the thoracic cavity. Then you're going to start relying more on costal breathing. The elastic rebound, of course, is what happens when the muscles relax. So when you have completely inhaled and the muscles responsible for inhalation have relaxed, that causes those elastic components of the muscles and the lungs to recoil. And the only thing that prevents the lungs just from collapsing in on themselves is that intrapleural pressure, which is always going to have a slight negative pressure to it. All right, so forced breathing is what we call hyperpnea. And this is going to involve those accessory muscles. And we are going to use not only muscles in inhalation, but we're also going to use muscles in exhalation, which during normal breathing we don't need to do. All right, so when we talk about rates and volumes, we're going to be studying this a lot in lab. So I'm going to touch on it here, but we're going to get into this in a lot more detail later on. So the respiratory rate is the number of breaths per minute. The volume of air per breath is going to be the tidal volume. So typically when you're at rest, it's about 500 milliliters of air. The respiratory minute volume, obviously, is going to be the respiratory rate times the tidal volume. So if typically you're breathing, 18 times a minute maybe, and you're moving 500 milliliters of air in each inhalation and exhalation, so that would be typical of when you're at rest. And now let's say you're doing some kind of physical activity, and now you're moving 2 liters of air and you're breathing 30 times a minute. You can see how your respiratory minute volume is going to change dramatically as you are exercising. So the respiratory minute volume is going to measure the pulmonary ventilation. And then we also have the alveolar ventilation. And this is the part of the respiratory minute volume that actually reaches those alveolar exchange surfaces. Remember, a lot of that air that you breathe in is going to be stuck in the conducting passages. So it's what we call an anatomic dead space, because no exchange of gases occurring in that conducting passageway. So the alveolar ventilation is the amount of air actually reaching the alveoli each minute. And this is going to be basically the difference between the tidal volume and the anatomic dead space times the respiratory rate. One of the other things to keep in mind is that the alveoli are going to contain more carbon dioxide actually than atmospheric air, because each time you breathe in, you have to get through all that air that's collected in the dead space, some of which will have been mixed in from previous exhalation cycles. So you're actually going to have sort of this mixing of air with the alveolar air that's mixing with the exhaled air that's in the dead space. So you're going to have more carbon dioxide in the alveoli than are in the atmosphere. All right, so we're going to look at these volumes in quite a bit later on. We're going to look at them in lab, and for that reason, I'm probably going to move ahead from this topic, and we're going to talk a little bit about the different volumes and the different kinds of capacities that we have in the lungs. And that would be this diagram right here. And as I say, we're going to get to this in a lot of detail in lab, so I'm going to skip over this part for this chapter and move along to some of the other concepts that we're going to study.